analyzed a lot, and it depends on the level and also the age. I analyzed the facet contact, and L1 to L2, 3, facet contact is very small. If you remove SAP completely, it may dislocate. So 1, 2, 2, 3, 3, 4. A lot of foraminotomy is very dangerous. So before surgery, please look at the facet contact area, especially for upper lumbar area. But the L4-5, L5S, facet contact is a lot. And also the IAP goes down and facet contact covers a lot. So after complete removal of SAP, facet contact is still remains 50%. So 4-5, 5S is safe. But be careful about for younger patient. For
Yes,
elderly patient, 4-5, 5S is okay. It covers after SAP complete removal, more than 50% is preserved. So it's safe. So please look at the facet contact area before surgery. This is very important. Level, age is very important.
I thoroughly agree with you, Dr. Koichi, because
Thank
at
you.
L1, 2, L2, 3, and even at L3, 4, usually the foramens are large.
Yes.
By nature, they are large, and therefore foraminoplasty or undercutting of the facet is not even required over there. It is usually at L4, 5 and L5, S1. And normally, we preserve it for middle-aged people with tight foramens. Your work was exceptional because you have done it in senile old people with scoliotic spines, rigid spines, and you have done an exceptional job. I mean, I really appreciate your work today. And I think you put it in a nutshell. Yes, there is significant overlap at L4-5 and L5-S1. And therefore, because of that significant overlap, it is easy to do a fistectomy or a partial foraminoplasty and get away with it. So perfect answer, sir. Perfect answer. Thank you so much.
Thank you.
Dr. Ziggy, has he joined us? Dr. Sameh?
Yes, yes, he already showed his screen and waiting for hours. Okay, Dr. Ziggy, you can start now.
Yes, Dr. Ziggy, welcome. The whole world is waiting for you to speak.
Well, I think the whole world will have to wait. Dr. Ziggy's opening another Zoom.
Whoa!
I think you need to get off the screen shares, Dr. Z, and come in again.
Yeah.
Yeah, you're opening up another Zoom.
But this Congress has been a wonderful experience. It has brought the best of the best together. After a long time, I can only express my thanks to Dr. Sameh, to you, Dr. John Bennett. You both are icons and inspirations to people like us. And a humble thank you.
Thank you.
That's all I can say.
Dr. Z, are you trying to get in again?
Yes, so can you hear me right now?
Yeah, just start all over.
Hi. All right, so I can share the screen, yes?
Yeah, share the screen.
Okay.
Yeah, share the screen. Start from the Zoom.
All right.
Share the screen, share screen.
1 second.
Okay, there you go. There you go, that's right. You're on the right track.
I hope so. I asked our IT to help me.
Yeah, just keep going. Okay, you gotta click the share button at the bottom of when it asks you to share. Okay, you're going into Zoom again. You don't want to go into Zoom. Okay, you need to go into your presentation. Okay, and we'll edit all this out. Don't worry. Yeah, go back. Get out of that screen. Stop that. Okay, now click the share screen button at the bottom of your Zoom.
Can you hear me right now?
Yes, I can hear you now.
Scroll down, and you will see a share screen button.
Yeah, go to the bottom of your Zoom. You're in the Zoom, right? And at the bottom of the screen is a share screen option. Do you see that?
Maybe I'll leave and go again.
Okay. It's a digital coffee break.
We have Dr. Hayati with us right now. Hayati, if you can unmute yourself, I will have a question for you. Dr. Hayati, can you unmute yourself, please?
Yes, sir.
For you.
Yes.
Dr. Hayati, you are one of the best UB surgeons I have observed in my life.
Thank you very much for your compliment.
Your talk was on the point that when there is a small disc herniation, you must do minimum stripping of the flavum
Yeah.
and directly reach doing a flavum preserving surgery. Now,
Yes.
where did you pick up on this idea from? How did this concept come to you?
Yeah. In my experience, if you touch to the interface between the dura and the flavum, also dura and the bony structures, and also if you touch to the interface between the dura and the disc,
Okay.
you should expect to the fibrotic healing. It's of course the flavum preserving technique is important, but is not enough. I saw in my revision cases that I always consider to the protecting of the flavum during the surgery, but unfortunately I saw the severe adhesions between the dura and the flavum in revision cases. So the pinpoint approach is very important. Pinpoint approach. The surgeon should have to make a optimal planning in a radiological workup. If you trying to find to the fragments into the canal, you should expect to the adhesions after surgery. Yeah.
Appreciate it. Thank you, sir.
I
Thank
think
you.
Dr.
Thank
Z
you.
is making progress.
Yes.
He fell off again. Try again, Dr. Z. That was you were on the way. There you go. Perfect. Okay, you got to make that screen bigger. There you go. It's one of those options. Go to one of those. There you go. Perfect. Okay, you're on a roll. That's perfect. You can start, Dr. Z. First, let me unmute you.
Can you please unmute yourself, Dr. Z?
Okay.
Okay.
Can you hear me right now?
Perfect. Yes.
It's okay.
All right. Okay.
Okay.
So my name is Vigi. I'm originally from Poland. I did my fellowship in the US. I also work in Scandinavia and Germany. And thank you very, very much for inviting me. It's a great pleasure for me. And I'm really extremely, let's say, impressed of the meeting. I'm practicing currently in Dubai, and my topic will be monoportal direct visualization for transforaminal. We saw today a lot of great presentations. So let me probably summarize about the monoportal transforaminal. Okay, then let me see. All right. Okay, so this is the approach which we are utilizing for decompression, for foraminoplasty, also for endoscopic lumbar interbody fusion. So basically, this is very, very universal, as you know, to go inside the disc space to epidural space to make decompression, remove the herniated disc, but also make the fusion. This Cambridge triangle, which we discussed today many times today, as you know, is constructed by the exiting nerve root, by the end plate, and by the superior articular process. The most important, if you are considering this approach, is do not irritate the dorsal root ganglion. Otherwise, we can create really neuropathic condition for the patient with some persistent pain in the future. So sometimes if the foramen is narrow, we have to do foraminoplasty, and we discussed today. So we have to remove part of the superior articular process to enlarge neuroforamen to be far away from the exiting nerve root, especially if we are considering to perform endoleaf, endoscopic lumbar interbody fusion, but also for some condition which require to decompress the nerve root. This is the patient positioning or setup which we are utilizing currently. So the most important is that the screen has to be in the front of your eyes. Don't put it somewhere on the lateral. You have to feel comfortable ergonomically. So it has to be just in the front of your eyes. And if you have additionally the scrub technician assistant, it's great. Majority of the procedure currently we are performing in light sedation, but also in general anesthesia. It's why anesthesia is absolutely necessary and intraoperative neuromonitoring. Usually I do my procedure in the prone position, but it's very important to open neuroforamen, so we can perform under general anesthesia, we can perform under monitorized anesthesia, occur IV sedation. Patient could be in prone, lateral decubitus position. Kyphosis is induced by the Wilson frame. It's a great device which is opening neuroforamen enlarged and makes our life easy during the procedure. So the most important, as you know, is to plan trajectory. So very important is T2 MRI, which we do before the procedure. We line up skin entry point ventral aspect of superior articular process and side of the pathology. We have different midline incision, depends on the morphology of the pathology, which we actually establish based on the axial MRI. So the planned trajectory and incision is very important for foraminoplasty. The area of the superior articular process is intersected by the line between the skin incision and the site of pathology. And here you can see this is this orange area on the slide. Then for planning trajectory and the skin incision, we have to mark vertical planning lines. So for the level 3-5, 3-4, it seems to be like 8 centimeter, 4-5, 10 centimeter, 12 centimeter, L5 is 1. We need to approximate values depend on the size of the patient, anatomy. Then we mark this space on AP, anterior posterior fluoroscopically, and play view, like as you can see here. And then we mark the rostocaudal, craniocaudal approach trajectory on AP X-ray, approximately around 15 degrees, connecting the upper aspect of the SAP with the middle aspect of the Cambys triangle. Then the next step is to mark the incision along the craniocaudal, rostocaudal approach trajectory at a predetermined distance from the midline reference, the lateral projection, the tip of the spinous process. You can see on the right side, you need to see clearly the spinous processes to determine it. So we are planning with the Cambys triangle. We depict the superior articular process. You can see the blue one, and the Cambys triangle on the AP and the lateral imaging. So this is our working area. This is what we have to see using fluoroscopy epilateral. So the smart radiographer is absolutely recommended to have. Then we advance the needle with the bevel facing ventral until the SAP target area and turn around 180 degrees to advance to the Cambys triangle with the tip just lateral to the medial pedicle. We shouldn't, of course, pass this medial border of the pedicle, otherwise we could be in a pleural space, we can punch the dural sac. So this is basically how the needle has to be placed, what we need to see on the AP and the lateral view for monoportal transforaminal. We resect the ventral aspect of SAP. We can do foraminoplasty if the neuroforamen is narrow with the bone reamers presented on the right side. And then the next step is to make obturation of insertion, the placing the working cannula and check the location under imaging and exactly how it should be. You can see on the radiographers on the right side. We visualize the lateral aspect of superior articular process, SAP, and the rostral cranial aspect of the caudal pedicle. So this C, SAP, and the pedicle, we have to absolutely localize, means we know where we are, and this is easy to proceed transforaminally. Then we resect the ventral portion of SAP to gain access into the lateral axis as presented here. So performing foraminoplasty. So we absolutely have to see the pedicle and the SAP, which resection is doing. Then we visualize the caudal index level pedicle is a principal anatomical landmark. This is extremely important, the index level of the pedicle. We confirm on the AP view fluoroscopically. So we have like a double confirmation from endoscopy and fluoroscopy that we're in the good position and safe position. The next step is dissect the epidural space, excuse me, a cranial to caudal index level pedicle. We are using bipolar cautery for any kind of bleeding. We resect ligamentum flavum and we visualize the traversing nerve root. So to identify traversing nerve root, make our work extremely safe. We know we are away from traversing nerve root and we can focus on only on pathology. We can mobilize this fragment from annulus using bipolar cautery. We can retrieve fragment using the punch, the grasping forceps. So all of the techniques we are utilizing to remove the fragments when the traversing nerve root is visualized. Then after that, we confirm the compression of the neural elements. If you can see this pulsating traversing nerve root intact, this job is done. And again, this pedicle is extremely important because of the location of the endoscope. But this is what we have to see when the decompression is done. We have some challenges during this procedure. So the first topic is when we cannot see the rupture fragments. Then we need to check fluoroscopically if the placing the endoscope is in the correct position. Sometimes if we perform procedure only in local anesthesia or superficial sedation, and of course we have the safe contact with the patient, and the patient during the procedure telling us about the leg pain, the patient is complaining, we need to make reinsertion of the needle through the working cannula. We have to restart needling if it's necessary because most probably the trajectory is the wrong. And also controlling verbally with the patient all the time. So you can see it here on the right side. This is far from the target, and if we make the reinsertion, it seems to be exactly targeting. So we have to start from the step A. Shouldn't rather, let's say, move the endoscope, better to go from the step A and make the reinsertion and be very close to the target. Thank you so much. Indeed, I would like to thank you, Dr. Kim and Christopher Hofster and Mohammed Assoud. So we had a spine meeting currently in Dubai about the endoscopy, and those guru of endoscopy were here. So I would like to really appreciate and thank you for inviting me with you today. Thank you so much.